All right, good morning. Thank you for coming, everyone, and thank you to Dr. Rishi and Dr. Giorgio for wonderful talks. So the next one is going to be a laser talk, and it's going to be roughly about broadly benign pigmentation in skin of color and actually all skin types, non-melasma, non-birthmark benign pigmentation, because I thought there was going to be a birthmark talk as well. So that's me in disclosures. So for laser, I think it's very important to understand sort of the fundamental basic principles behind the devices that we use. And so I'm going to spend a brief amount of slides going over basic laser tissue interactions and kind of explaining the four major ones that are relevant to benign pigmentation treatment. And then we'll get into some clinical applications. So first of all, terminology. We have to be basically speaking the same language when we talk about lasers. And the basic laser parameters to understand, and I apologize, this is review for almost everybody here, but wavelength, fluence, spot size, pulse duration, and density. We have to really understand what these terms mean in order to apply the lasers to the conditions that we want to treat. Secondary parameters of interest, and in particular for short pulse laser and benign pigmentation, are power, irradiance, and beam energy. Okay, beam energy coming into play when we talk about fractional laser. And finally, what are we targeting? The chromophores within the skin typically are going to be water, hemoglobin, and melanin. There are a couple others, but these three are the main ones that most lasers tend to target. Laser classification. We know Dr. Rishi has already explained this beautifully, but fractional versus non-fractional, ablative versus non-ablative, and long pulse versus short pulse. All of these have implications in terms of skin type and their appropriateness in different clinical situations. So being familiar with these terms and understanding them and how to apply them is very important. So let's talk about laser tissue interaction. There are basically four mechanisms of action that we should understand when we talk about treating benign pigmentation with lasers. The first is selective photothermolysis, published in 1983 by Anderson and Parrish. The second is fractional photothermolysis. Dr. Manstein, as well as Dr. Anderson and the others published in 2004. Selective photoacoustolysis. This is when we have a very short pulse laser that is non-fractional. And then finally, thermionic laser-induced breakdown. This is a fractional short pulse laser. So let's start at the beginning. Selective photothermolysis. Very briefly, we have a chromophore, okay, and we use a wavelength that is specific to that chromophore. So it only gets absorbed by that chromophore, theoretically. We deliver enough energy into that chromophore in terms of fluence, enough to affect some sort of thermal change, okay, usually destruction, essentially, of that chromophore. And importantly, that energy is confined to just that chromophore. It doesn't expand beyond. And so the optimal energy confinement was the key, really, and that was due to basically an optimal pulse duration. It had to be less than the so-called thermal relaxation time of the target chromophore. And the thermal relaxation time was proportional to the size of the target chromophore. In 2004, that theory was evolved to basically become fractional photothermolysis, which is basically the underpinnings for almost all of our laser technology these days. But it's the same concept, but essentially using a single beam and splitting it into thousands of little micro beams. And you get novel effects when you do this. You can have deeper penetration, for example, but you also get sparing of non-lasered skin. And this reservoir serves as a nice healing bit so that you can decrease your risk, decrease your downtime, yet still achieve a reasonable clinical effect. And so this is old news, but still extremely relevant and very important to understand. One particular laser, for example, the 1927 nanometer thulium fiber and or diode laser is very highly absorbed in water. And we can get these fractional patterns of injury that result in minimal downtime, but generally improved skin quality. A couple of us sort of put this together in a little review for Asian patients with fractional resurfacing. But what happens when the target size becomes really, really small? Then we really need to think about the pulse duration of the laser. It has to become very short. Otherwise, we don't get confinement of energy. And when we don't get confinement, we get nonspecific damage. It tends to increase our risk for unintended adverse effects. So this is from the tattoo removal literature, and this is kind of how we understand short pulse laser. Basically, there was out of Livermore, Young and colleagues, they did a little experiment here where they took 50 nanometer graphite particles and irradiated them with picosecond pulse laser. And they found that the temperature of the particle never really exceeded the melting point. Okay, so you would think from photothermolysis, that would maybe be one way that these could be destroyed, as they get melted, okay, by the heat. But actually that didn't happen. Instead, basically a pressure wave was generated because the pulse durations were so short, and this pressure exceeded the fracture threshold of the particle, so it basically destroyed it mechanically. Okay, it broke it into small pieces. And the optimal confinement of that photoacoustic energy for these 50 nanometer graphite particles was very, very short, 10 to 100 picosecond pulse duration. To this day, we still don't have commercially available lasers in dermatology at that pulse duration. And so this was so-called selective photoacoustolysis. On the one hand, we have photothermal change where we deliver energy slowly, relatively slowly. I mean, these are milliseconds, so it's still very fast, but relatively slowly, and things get heated up and the heat changes them. On the other hand, we deliver energy extremely rapidly, and the energy gets converted into a mechanical force that destroys the target. And it turns out that pulse duration is extremely important for this. And for the optimal sort of acoustic thermal pressure index, you really need something that is kind of 500 picoseconds and under for the majority of that energy to be photoacoustic or photomechanical. Even at 600, 700, 800 picosecond pulse duration, you're still getting majority photothermal energy, as you can see here. So what's the best pulse duration for small particles? Hard to say, but it can be mathematically calculated. And there was a little study here, again, out of the Wellman Center, where there was an estimated optimal pulse duration, essentially. And you can see it's extremely short. Okay, these are common particle sizes in tattoos, 40 nanometers, 100 nanometers, whatnot. 19 picoseconds, 70 in dermatology, unfortunately, we don't have these lasers quite yet. The shortest pulse duration we have is about 250 picoseconds, which is still better than nothing and really quite short, but that would be optimal for maybe a 150 nanometer particle. And this was a little homebrew experiment. You can see very clearly the effect of pulse duration on the clearance of these inks. The shorter your pulse duration, as long as everything else is the same, energy, wavelength, et cetera, then the short pulse duration will always win. And tattoo removal these days is quite satisfying because there's usually not really a tattoo that we can't treat anymore with the picosecond laser. In 2012, there was this article published in the journal Biophotonics that described a novel mechanism of action for short pulse laser, and this was when the picosecond beam was fractionated. Okay, and it was called laser-induced optical breakdown in this particular paper. And the mechanism of action is actually a thermionic laser-induced breakdown. And I'll illustrate it as a little cartoon here. We have a chromophore, so it always starts with a chromophore still because our pulse durations are not short enough to achieve so-called multi-photon ionization. But we have a chromophore, and that assists the process. So the chromophore in this case is usually melanin, and the laser, the picosecond laser in this case, is at a very selective wavelength and of sufficiently high irradiance. Irradiance is power density, watts per centimeter squared. Irradiance is the key determining factor in this entire mechanism. It has to be of a sufficiently high level in order to achieve so-called ionization, and it has to cross that threshold where we get electrons that get freed from nuclear orbit and become seed electrons. They just essentially exist. And these seed electrons, because the picosecond pulse is still going, they are very absorptive. They absorb the energy, and they become high-energy electrons. Okay. And these high-energy electrons, they start to collide with other molecules in their vicinity, and they transfer that energy to these molecules, thus potentially exceeding ionization threshold again. And so where you first had one, you now have two. They can also recombine with the original ion, and in so doing, they decelerate in space and release a broadband photon, essentially, that is visible light. These electrons continue to absorb energy, okay, because this happens instantaneously, but for this cartoon, it happens very slowly. And now we get two electrons, and that process repeats. It's a cascade ionization, essentially. And instantaneously, we get a superheated ionized gas, what we call plasma. And plasma is extremely absorbent. It in fact shields everything downstream from it from further laser exposure, but it absorbs that continuous laser energy and it converts it because the temperature is so high, and this is now a gas. It expands extremely rapidly, and that induces a shock wave It is a supersonic expansion, essentially. And that shock wave is your first mechanical form of damage. All right, heat has been transformed instantly into mechanical pressure. On the other hand, the heat, because it is thousands of Kelvin hot, it will instantly vaporize these microscopic little steam bubbles, a process called cavitation. Okay, and these steam bubbles form, and they too get superheated and they start to expand. And the advancement of that bubble wall starts to just crush things, in its path, basically, and destroy, again, mechanically, everything in its surroundings. Okay, and this process is also thought to play a major role in the removal of benign pigmentation and/or tattoos with short pulse laser. So bubble wall expansion is mechanical damage number 2. So basically, we have a wavelength of light that is selectively absorbed by tissue chromophore. So selectivity is still extremely important in this situation because this mechanism relies on chromophore. Okay, and it cannot be achieved without chromophore at the pulse durations that we have currently in dermatology. Plasma is created. Okay, so this is a different mechanism of action than the photothermal mechanisms that we know of. The damage ensues because of these shock waves and cavitations, and they trigger a biological response, usually some sort of remodeling, that kind of thing. And you can actually hear it, okay, because it's a supersonic expansion. So you get essentially a sonic boom. And this is what we call thermionic laser-induced breakdown. And you can see it. And that's really the key to this entire thing. Once you understand this process, you can see almost every stage of it, and therefore you can tune your clinical treatment in real time for any skin type, in any situation, and know that you have at least tried to achieve the best possible setting for each individual situation, because these endpoints are extremely granular. They can be differentiated. For example, on the far left column there's 0.1 difference in terms of fluence between those spots, yet there's a visible clinical difference in how they appear. And that's a very, very small margin, and it can only be achieved with ultra-short pulse laser. When you fractionate that beam, the injury looks like these little vacuoles. Usually in the epidermis. Rarely does it penetrate beyond that. But within a day or two, you see these at very short pulse durations and very low beam energies. It's a little bit misaligned, but it's a 1.3 millijoule microbeam, whereas the 8 nanosecond laser, on the other hand, was, I think, at 6 or 7 millijoules per microbeam, yet there was no thermionic induced breakdown because the pulse duration is too long. 8 nanoseconds, although 8 nanoseconds is very short for a nanosecond pulse laser, but it still is not sufficient to achieve the effect that we need because it doesn't cross the threshold. And it's not hot either because this is a little homebrew experiment. We just pulsed the laser 100 times, and then we used an IR camera to measure temperature, and there was really no change in temperature, at least immediately. There was a delayed increase, and that was published by Dr. Tangeti. But when we used the 8 nanosecond laser, immediately there was a large increase, a very measurable increase in heat, comparable, in fact, to a traditional non-ablative fractional laser, which we know is very hot. And so it's not very hot. What happens to all the energy? As we've seen, that energy gets converted. It gets converted into mechanical force, and more, actually, because it gets converted into light, it can sound, as well as mechanical force. And you can see it. This is a fractional beam here, and you can see starting at 1.3 millijoules, there's these little flashes of light. That's when the electrons start to decelerate in space and they release, it's called Bremsstrahlung emission or something like that. And basically, it's a broadband photon that gets released, and you can see it through your laser goggles. So it can guide you in terms of what setting to use, or at least the minimal therapeutic dose that is required to achieve this biological event, so-called laser-induced breakdown. And it's tunable. You can see here on skin types 2, 3, 4, and 5, the threshold to achieve ionization is progressively lower. In a skin type 2 patient, we have 1.7 millijoules before we start to see those flashes of light. And those flashes of light only happen when we get that mechanism coming to completion. But in a skin type 3-4 patient, 1.3 millijoules was sufficient, and a skin type 5, 0.9 millijoules was sufficient. And so this is a very clear way that we can adjust our laser settings in real time for any patient at any time for any reason. And it's very simple. It doesn't require a lot of thinking. And we see it instantly, and anybody can apply it. And this has been published many times in terms of the clinical effects. Dr. Brower and Dr. Hieronymus showing some increased collagen, elastic fibers, et cetera. And so the endpoints for picosecond laser are a little bit additional to what we see with the nanosecond stuff, because we get the light, we get the sound, and we get the cavitation. The cavitation is normal. This is the whitening that we see after any short pulse laser. It's just a whitening of the skin, but we get that plasma-induced luminescence. We get the audible sort of crackle, and we can actually feel it. If we've treated tattoos or even benign pigmentation, if you put your hand close to the laser, close to the tattoo, you can feel it's like a dull thud, and that's the shock wave. So, and in fact, you can even see it sometimes when the pulse duration becomes very short. There's a pattern of injury that essentially is a shock wave that you can see. So that's basically the laser tissue interaction. Now let's go into just a variety of different cases, benign pigmentation, because I mean, in our practices, that's something that we see very often. Maybe even the majority of what we see is pigmentary related. So common pigmentary concerns in skin types 1 and 2, we get freckles and sunspots, SKs, and just diffuse actinic dyschromia, it's bronzing and sallow skin, stuff like that. So, this gentleman with some seborrheic keratoses, otherwise looking pretty good skin-wise, but in this kind of situation, there's a lot of options. Almost anything will essentially work. Liquid nitrogen, electrocautery, and then anything from a non-ablative to an ablative fractional or non-fractional laser essentially will get to this goal. In this situation, I used an erbium YAG, fully ablative laser, and just resolved them in one shot. In a skin type 1, skin type 1 patient, this is a common sort of, there's this dusting of benign pigments, freckles, et cetera. And honestly, cosmetically, you wonder, she wanted very clear skin. Some people would prefer to maintain some freckles, in which point it becomes a little more complicated because you got to pick and choose which ones to treat. Skin type 2, again, very common sort of just hyperpigmentation, and some picosecond laser, we can sort of get rid of that skin type 2. Again, a couple of treatments later. Even around the eyelids is easy to miss them because they're under the shields and stuff. So that's why I did a second treatment on her, because she had freckles still around her eyes. It looked very odd. Older sort of individual getting some actinic damage, also some AKs and precancers, things of that nature. Photodynamic therapy, in my opinion, is an excellent choice for this type of situation. You can modify the procedure by adding in a few lasers and lights, et cetera, and then you can get a good cosmetic result as well as a reasonably good medical result as well. And some good rejuvenation too, the wrinkles and whatnot. But she also had some Botox, so that's confounding things. Skin types 3 and 4. It's basically the same stuff, but you get more dermal melanocytoses in skin types 3 and 4. And that's where it becomes very tricky. And so a Hispanic patient here with a mixture of small and large SKs and solar lenticos, et cetera. Also just dull, roughened, sallow skin, enlarged pore size, things of that nature. This is where the fractional beam becomes really useful. As you saw with Dr. Brower's paper, the increase in elastic fibers and collagen fibers is very nice just to rejuvenate. This Japanese woman, very similar situation, but with the fractional picosecond laser, you can get sort of like this glass-like skin. It's like makeup but no makeup sort of look. Melasma, but melasma is always superimposed. There's always something superimposed on top of the melasma, and there's like a lentigo or something, and so that's where you got to be very selective. That's the selectivity is the most important thing, because you're going to treat these spots, but you don't want to treat them to a level that the melasma also gets lasered, because then you run into trouble. So that's where a distinguishment can be made between a nanosecond laser and a picosecond laser. It's just more selective. This woman, yes, had some melasma, and then it disappeared. These are Hori's macules. This is bilateral nevus of odo-like macules. They're basically dermal pigments, and they look like melasma, and they mimic melasma, but they actually respond to treatment, unlike melasma, so they go away. Skin types 5 and 6, again, you get the dermal lines, but then you get the much darker pigments like the DPNs, okay, and that's a very, very common concern in 5s and 6s. This is just overall, the pigment content is just much higher, and so more treatments are required. lower settings usually, and just a little bit more caution. And skin type 5, this is a very common situation. We get the perioral, periorbital sort of darkening. We get these little DPN-like lesions. And just overall, her skin looks a little bit sallow, a little bit dull, and it's contributing to an overall aged appearance. But with a little bit of laser, she looks just brighter. And this gentleman here, these, if you saw it on a skin type 1 or 2 patient, you could probably just blast them away. But in this patient, this was like a lot of treatments, probably like 3 or 4 treatments, and it's still not resolved. It's like 70% gone. But that's kind of the expectation for this skin type. And that has to be clearly communicated prior to treatment. Skin type 4, 5, again, these little freckles, they respond quite well, actually. This just generalized dyschromia, active guy, always outside, and he's just got, nothing really specific, but just overall hyperpigmentation. And a 1927 nanometer fractional laser, usually pretty good for that. And then melasma, very difficult to treat. Obviously not perfect, but some improvement. Skin type 5, 6. Combination of laser, topical, sunscreen, always. DPNs respond extremely well to picosecond laser because the selectivity can actually be perfect if it is tuned properly. Then, because these things are like 1 millimeter or ½ millimeter size, you never have a laser beam that's that small, so you really have to be selective in this kind of case because it's always going to be a 2 millimeter spot, and so you don't want a 2 millimeter white spot on the skin. That would look terrible. This is a young woman. She wanted some of her freckles removed, but not all of them. And so that's what we did. And then there's just a potpourri of other things that we might encounter, like stasis hyperpigmentation, for example. This can respond to fractional picosecond laser, but it's very troublesome, and it takes a lot of treatments, and it just may not be worth it, honestly, but we did publish this in 2017. Argyria, if it ever happens to wander through your office, it's extremely responsive to picosecond alexandrite laser. And it's instantaneously responsive, actually. It's very interesting. Once you laser it, it disappears right away. You don't have to wait. So that's nice, but it's very, very painful. Minocycline-induced hyperpigmentation also can respond to mid-wavelength short pulse laser, and resolves pretty good. Then you get complications from all sorts of things. This person had a chemical peel all the way around her back, and then gentle treatments like fractional 1927s are really good for this. It just takes a lot of treatments, but patients are usually very happy. Again, this person had rebound, from melasma, and then more than rebound, actually. This is actually a true burn. You can see these there's circular little spots on her face, so it's probably not a good idea to do that. But the 1927 can fix this, so that's useful. Even inverse dermatoses, like this was in the case of inverse psoriasis, an Indian woman. The psoriasis was resolved because psoriasis is now resolvable, but the pigmentation remained. And again, a little bit of laser could get rid of that. This was a patient who came in with a laser hair removal burn, so scars and hyperpigmentation in that regard. You can, generally speaking, improve this quite a bit nowadays. It's not the end of the world. It's still not perfect, obviously. There's still a bit of a scar there, but it's still much better. And then this guy, I think he had looks like an IPL or something, I don't know, maybe a fractional laser. He had this treatment done in Dubai and then burned his face off. And then he came to see me, and we got some improvement, but not perfect, but still better than it was. So basically, benign pigments of almost all variety can be treated as long as we obey and understand simple laser rules and simple laser mechanisms. And the nice thing about short pulse laser in particular is that you can see it right away. So you can kind of measure your treatment as you go, and you don't really have to guess. And that's it. Thank you very much.